Good afternoon, everyone. Welcome to today's session, our first hypertension and cardiovascular disease interdisciplinary echo session of the year. If you joined us last year in September, you might have seen me. I joined the team recently, so in case you're new, my name is Benita Arokiaraj. I serve as the Population Health Analyst and Echo Lead for the Constellation Regional Collaborative team, within which this Echo series is housed. And today I'm joined by my colleagues from the Constellation Regional Collaborative. Since this is our first session of the year and we have a new team member since the last time we all met, we would like to go over brief introductions and then go through the agenda and other slides. So over to you, Agner.
And
Oh,
I
you're
was
muted.
mute. Good afternoon, everybody. My name is Agner Munoz. I'm a community health specialist for the Constellation Quality Health Regional Collaborative and a South Carolina CCHW certified community health worker. It's a pleasure to be here. I'm the latest CRC member. I'm happy and excited to be here with all you all. Sydney?
Hey everyone, my name is Sydnie Fleming. I am the Outreach and Community Engagement Specialist with the Constellation Regional Collaborative. I'm also a community health worker, so great to have you all here. Maxine?
Good afternoon, everyone. I am Maxine. I'm the program manager for the Constellation Regional Collaborative. We are just so excited to kick off our 2026 Echo Series and delighted to have Benita as the lead and Agner and Sydney also as presenters today.
Thanks, Maxine. Moving on to the next slide. This is just a look at the agenda for today. We'll begin with a quick round of introductions from participants, as it's already started in the chat. Feel free to put in your name, organization, your role, and where you're joining us today from. We'll also go over introductions of our subject matter experts who are on the call today. And then later on today, we will have a didactic presentation by myself and a few of my colleagues on the guidelines as shared earlier. We'll have a Q&A and end the session today with, just a look into what we can expect from future sessions in this year. So I can't really see the participants right now because I'm sharing slides, but do we have any of our subject matter experts on the call today? If so, we'd be happy if you came off mute and just introduce yourself to all the participants today.
Well, I'll go ahead and go first and break the ice from our side. My name is Don DePetty. I'm a physician here at the University of South Carolina School of Medicine, former dean, also a board member of Constellation Quality Health, and my interest is in internal medicine and primary care, but I've also had a long-standing career in hypertension and vascular disease and biology in the area of clinical pharmacology of hypertension as well as the pathophysiology of hypertension. I'm just thrilled to have another year and to open up 2026, and I look forward to the team and the presentations all year long.
Wonderful. Thank you, Dr. DePetty. And I think Valerie just joined us. Valerie, Emily, and other subject matter experts. If you're on the call, feel free to introduce yourself.
Hi, everyone. I'm Emily Ridley. I'm a clinical pharmacist based out of an internal medicine residency clinic within Prisma Health in Columbia, South Carolina, where I serve primarily low-income urban population, some rural too, as we're a center where we end up getting folks from a lot of places in the state. But on a daily basis, I work with our patients in our clinic, helping with improved hypertension, and diabetes, of course, goes hand in hand with that too. I also worked with efforts across our health system and quality improvement efforts regarding hypertension control, and worked with PAHO and the Hearts of the Americas program. Nice to see so many folks on today. I'm looking forward to the talk. Thank you.
Thanks, Emily. And all our participants, especially if you've just joined the session, feel free to drop in the chat your name, organization, role, where you're located, and optional icebreaker to drop in a GIF on how we're all feeling today.
I don't mind going ahead to introduce myself. Hi, everyone. My name is Valerie Perez, and I currently work at the Homeless Services Network of Central Florida. And I am one of the coordinators working on our continuum of care within the homeless response system. And I am also an MBA graduate with a focus in marketing research and social media analytics. A lot of my work really stems into building communities, educating and training other organizations and people on how to work with youth and young adults, as well as how to work and engage with people with lived experience of homelessness.
Thanks, Valerie. And Dr. Bretler let me know that he's traveling and won't be able to attend, but he's a practicing physician with a lot of experience in chronic disease management. And then we have Honey Estrada, who is a community health worker and brings firsthand insight from the CHW field and is a strong advocate for health equity. We also have Dr. Lackland, who has worked with the organization for many years, is also another nationally recognized leader in the hypertension and cardiovascular health space. All right, so I can see some GIFs coming in and other introductions in the chat. Thank you all for participating. We will move on. So today's didactic presenters are the CRC team members. So myself, I am a public health professional, bringing in around 4 years of experience in data-informed program evaluation, implementation, and delivering technical assistance to community partners. A lot of my experience comes from health equity programming, previously in violence prevention, and now currently in hypertension and cardiovascular disease and management. Other didactic presenters are two of my colleagues, Sydnie and Agner. You guys can feel free to share a little bit of your bio before we start with our presentation today.
Thanks, Benita. Again, Sydnie Fleming. I'm a community health worker bringing lived experience and 5 years of public health expertise, also some research expertise before my public health career. So mainly I'm helping bridge gaps in healthcare access through education, outreach, and advocacy. I'll pass it to Agner.
Thank you, Sid. Well, my name is Agner Munoz Vazquez, born and raised in Puerto Rico and living in South Carolina since 2017. And for the last 8-9 years, I've been working as a CHW, primarily working with Latino population here in South Carolina in my previous employee. And now I'm the community health specialist, and I'll be leading eventually what we our project will be the community care hub, focused on cardiovascular health and chronic disease. I'm happy to be here, very excited to see some of the people that I know here in South Carolina. T, Mike, shout out to you guys. Thank you, Benita.
Thank you. Alrighty, so let's get started with today's didactic presentation. So the reason why we're all here today is to discuss the revised American College of Cardiology, American Heart Association, and other sister organizations' guidelines for the prevention, detection, evaluation, and management of high blood pressure in adults. So these revised guidelines were published in 2025, replacing the 2017 guidelines. This guideline is intended to be a resource for clinical and public health professionals. Clinical practice guidelines provide recommendations applicable to patients with or at risk of developing cardiovascular disease or CVD. The focus is on medical practice in the US, but these guidelines are relevant to patients throughout the world. These guidelines are intended to define practices meeting the needs of patients in most, but not all circumstances, and should not replace clinical judgment. In our presentation today, we will be covering what the ACC AHA Joint Committee deem class 1 or strong recommendations, and mostly what they share as the high quality of evidence based on data strength and consistency across many different research and program studies. And what we share today would also be relevant to our ECHO audience. And there are also many topics which coincide with the Constellation Regional Collaborative program lines, which we will highlight throughout our presentation as a means of introduction to our work, especially for the new participants. Over to you, Agner.
Thanks, Benita. Good afternoon, everyone, again. It's truly an honor to be here today and talk about a topic that I believe is critical to overall health, not just for individuals, but for the communities we serve. And before we dive deeper into blood pressure management, I want to start by sharing a few important facts about high blood pressure to help set up the context for today's conversation. To put these numbers in the slide in perspective, high blood pressure is a much bigger issue than many people realize. Back in 2023, it was the primary or contributing cause in more than 660,000 deaths in the United States. Nearly half of all adults, which means about 1 of 2 people, have high blood pressure. And even more concerning is the fact that only about 1 in 4 adults with high blood pressure has it under control. These numbers are exactly why awareness, prevention, and support around blood pressure management are so important. Can you go to the next slide, Benita, please? So blood pressure classifications and treatment goal. So now that we understand why high blood pressure matters and how widespread it is, let's take a look closer and how it's classified and what the treatment goals actually are. Before we look at the numbers, it's helpful to do a quick reset on what those numbers mean. The top numbers or systolic is the pressure when the heart beats. The bottom number or diastolic is the pressure when the heart relaxes between beats. With that in mind, it's helpful to understand what changed and what hasn't changed in the latest guidance from the American College of Cardiology and the American Heart Association. The definition of high blood pressure is still the same, has not changed. It's still defined at 130/80 or higher. What has changed is the emphasis. The focus now is less on debating numbers and more on how care is delivered and how we support people in keeping blood pressure control over time. That includes team-based care, where clinical teams and community partners work together to support patients. With that in mind, this might sound simple, but knowing your blood pressure number is one of the easiest ways to prevent problems down the road. Once we know the goal, the next step is understanding where someone falls today. Blood pressure is grouped into categories, and each category helps guide what actions to take. Let's walk through those categories. Normal blood pressure is less than 120/80. This means the heart and blood vessels are doing well, and this is where we want to stay. The next one is elevated blood pressure, when the top number is between 120 and 129, but the bottom number is still less than 80. It's not hypertension yet, but it's an early warning sign and a great time to focus on lifestyle changes. Hypertension stage 1 is when the top number is between 130 and 139, or the bottom number is between 80 and 89. At this stage, blood pressure is high enough to increase health risks, so lifestyle changes become very important, and for some people, medication may be added, depending on the overall risk. Hypertension stage 2 is when the top number is 140 or higher, or the bottom number is 90 or higher. This means blood pressure is clearly high and needs closer follow-up. Lifestyle changes in this category are still the key, but medication is usually needed to bring those numbers down safely. And hypertension crisis is when the top number is higher than 180 or the bottom number is higher than 120. This is not something to wait on. It's a medical emergency and requires immediate medical care. And after all this has been said, the most important takeaway is that knowing your number early makes it much easier to take action and protect your health. Next slide, please. So now that we have talked about blood pressure numbers and treatment goals, let's focus on what makes the biggest difference for most people. Blood pressure management, which is a focus on lifestyle, and psychosocial factors. The new guidelines are very clear about one thing. Lifestyle changes are the foundation for preventing and treating high blood pressure for everyone. That means focusing on healthy weight, eating hard, healthy foods, cutting back on salt, getting more potassium from foods, staying physically active, and managing stress. For adults who have overweight or obesity, even a modest goal, losing about 5% of body weight, can make a meaningful difference in lowering blood pressure. When it comes to food, one of the most helpful things for blood pressure is eating in a hard, healthy way, like the DASH eating plan, which stands for Dietary Approach to Stop Hypertension. That means eating more fruits and vegetables, choosing whole grains, and including low-fat or non-fat dairy products. This style of eating naturally provides nutrients like potassium, magnesium, calcium, and fiber, all of which support healthier blood pressure. Salt matters too in our eating habits. The general goal is to keep sodium intake under 2,300 milligrams a day and even lower if possible. If you do most of your cooking at home, potassium-based salt substitute may help, but they are not for everyone. So people with kidney disease are those taking certain medications should check with their provider first. Overall, getting more potassium from foods, especially fruits and vegetables, can make a real difference for blood pressure. Physical activity also is another powerful tool. Moving your body regularly, whether it's walking, structured exercise, strength training, disc golf, helps prevent and lower high blood pressure. Stress matters too in these new guidelines. Practice like meditation, breathing exercises or yoga can support healthy blood pressure. And in short, finding ways to relax is good for your blood pressure everywhere. And since we're taking honestly about stress, we also have to talk about alcohol. Probably not everyone will like these new guidelines or agree with this, but your blood pressure does better when alcohol is limited. The recommendation now is no more than 1 drink a day for women and just 2 for men. And less is always better. The big takeaway is that small, consistent lifestyle work together to protect your heart, brain, and kidneys. And that's the most important thing. Next slide, please, Benita. And blood pressure management, which is pharmacologic. Lifestyle changes are powerful, and for many people, they make real difference, but they are not always enough for their own. And that's where medication becomes part of the conversation. The chart shown in this slide shows that deciding when to start blood pressure medication isn't just about number on the screen. It's also about the whole person. If someone's blood pressure is very high, like 140/90 or higher, medication usually starts right away. But if the numbers are still lower, around 130/80, we take a step back and look for other factors. For people who already have heart disease, pass-through, diabetes, kidney disease, or higher risk of heart problems, medication starts sooner to protect the heart and prevent future issues. For others without those higher risk conditions, lifestyle change comes first. Things like eating healthier, moving more, and managing stress. If blood pressure doesn't come down after a few months, then medication may be added. So the takeaway is simple. Treatment decisions are based on both blood pressure numbers and overall heart risk. Next slide, please. And when we talk about overall health risk, we're really talking about other conditions that often travel with high blood pressures. These are the comorbidities, which simply means other health conditions a person had at the same time. A good example is diabetes. More than 80% of adults with type 2 diabetes also have high blood pressure, and hypertension, which is about twice as common in people with diabetes compared to those without it. When someone has both conditions, the risk of heart disease more than doubles. Obesity is another major factor in here. As weight goes up, blood pressure usually goes up too. Obesity and high blood pressure often shows up together, along with other issues like high blood sugar or unhealthy cholesterol. When these problems cluster together, they put extra strain on our heart, kidneys, and blood vessels, increasing the risk of heart disease. That's why managing weight is such an important part of protecting overall health and not just blood pressure alone. Now that we have covered blood pressure and over risk, I'm going to turn it over to Sydnie, who will walk us through the plan for care hypertension, including important considerations during pregnancy. Sydnie, the floor is yours.
Thank you, Agner. So the overarching theme of guidance when it comes to plan of care for hypertension is really utilizing a team-based approach for patients. And just to officially define that from the guidelines, team-based care is a health systems level organizational intervention that incorporates a trained multidisciplinary team and is frequently implemented as part of a multifaceted approach to improve hypertension outcomes. So what does that mean? The use of multidisciplinary teams can be especially effective in assessing and addressing individual upstream drivers of health, such as access to necessary medications and other barriers, to optimize a patient-centered approach to care for all patients with hypertension. And this will reduce the disparities that we see in hypertension control. The guidelines also specifically talk about the division of care within the multidisciplinary team, which you can see in the table on the slide right here. And when a healthcare team clearly divides up who does what based on the patient's needs, and each team member's scope of practice, the primary clinician isn't responsible for everything, which, as we know, can lead to some gaps in the patient care. So that's really why they're recommending the team-based approach. This really frees up the primary care provider to focus on the more complex or urgent patient problems. And also, these other team members addressing the other issues is just more in their scope of practice. So, and I just want to briefly touch on the plan of care guidelines for adults with uncontrolled hypertension. And the definition of uncontrolled hypertension is the average blood pressure above the patient's goal blood pressure. So for adults with uncontrolled hypertension, an integrated treatment model, so accurate blood pressure measurement, promote treatment, patient engagement, and ongoing review is recommended for blood pressure control. Telehealth and health information technology by phone or video call, which is synchronous, or asynchronous, which is just like a text or an email, is really beneficial to improving blood pressure control, also access to care and adherence to the standards of care, and should be incorporated in hypertension management. And a great way to do this is through a self-monitoring blood pressure program with Healthy Heart Ambassadors. So how is the CRC emphasizing these guidelines? So the CRC program line emphasizes the core strategy of team-based care by supporting both the clinical and community sides of team-based care. Through case-based learning in our ECHO series, our audience members learn how to apply evidence-based practices across disciplines. Within our community care hub, it will directly address upstream drivers of health, ensuring patient needs are addressed holistically. And our Constellation Regional Learning Collaborative strengthens the system-level implementation of team-based care. The collaborative environment really among the participating organizations really supports the consistent patient-centered care. Next slide, please. And now we're going to switch gears a little bit and talk about hypertension and pregnancy. So the guidelines cite the American College of Obstetricians and Gynecologists definition of hypertension in pregnancy, which is a systolic blood pressure greater than or equal to 140 millimeters of mercury, and or a diastolic blood pressure greater than or equal to 90 millimeters of mercury. So hypertensive disorders of pregnancy, or HDP, are increasingly common in the United States, affecting about 15.9% of deliveries, with the highest prevalence experienced by Black and American Indian and Alaska Native women. Also women aged 35 years or older, and women with obesity. So the chart on the right defines all the different hypertensive disorders of pregnancy, and I'll specifically highlight that gestational hypertension is the new development of hypertension at or after 20 weeks of gestation, and in the absence of proteinuria or other signs of preeclampsia. Sorry, we're trying not to get too clinical, but this part is a little bit clinical. So gestational hypertension is associated with an increased risk of maternal and fetal or neonatal adverse events, and up to 30% of women with gestational hypertension ultimately develop preeclampsia. Next slide, please. So blood pressure management during pregnancy is pretty complicated because many of the commonly used antihypertensive medications are contraindicated or because they're harmful, potentially harmful to the fetus. So when necessary, there's two medications right there on the slide, and I'm not even going to try and pronounce them because I've tried a few times and I just don't want to butcher it. But these are the preferred first-line agents here. However, following delivery, so postpartum, many antihypertensive medications can be safely used again, but should be individualized and patient-centered. What's really beneficial is home blood pressure monitoring for postpartum individuals. It's been associated with lower blood pressure and may also help compensate for those racial disparities that we see in the office-centric follow-up strategies. And I think that is all for the hypertension in pregnancy.
Thanks, Ed. So the guidelines end by addressing the evidence gaps and future directions, basically where to go from here. So as Agner covered in one of the initial slides, among adults with hypertension in the US, most are not controlled to less than 130/80. More than 50% are unaware that they have hypertension. So population management strategies are just beginning to utilize the EHR and consider community-engaged strategies to identify those with undiagnosed or uncontrolled hypertension to focus resources accordingly. There's a need for research regarding effective screening methods and for more effective implementation strategies within and outside the healthcare system to control blood pressure and reduce cardiovascular disease risk. Next, accurate blood pressure measurement remains a major challenge. Use of blood pressure monitors that have been specifically validated for accuracy is advised, and one way to check whether the monitors you have are validated or not is by using the link on the slide, validatebp.org. The guideline recommends using that link to check whether blood pressure monitors have been validated for accuracy. And reliance on cuffless devices, including smartwatches, for accurate blood pressure measurements should be avoided until these devices demonstrate greater precision and reliability. Next, further studies are needed at the intersection of blood pressure, including upstream drivers of health, for example, including those who are uninsured or underinsured, to allow more precise predictions of needs and better focus prevention and management. To ensure optimal application of guidelines and evidence-based approaches that are effective and equitable for all groups, the blood pressure treatment thresholds and treatment targets for different subpopulations also needs to be further clarified. And thanks, Maxine, for dropping the link in the chat. So how does this ECHO series support the revised and updated guidelines? Coincidentally, based on a poll we sent out last year and discussions with our subject matter experts and colleagues, we have identified 4 focus areas for our 2026 ECHO series, which align perfectly with the guidelines we just covered in today's presentation. So as listed on the slide, our 4 focus areas for this year are: 1, addressing the upstream drivers of health impacting hypertension management, which includes food insecurity, housing, transportation access, etc. 2, addressing the role of community health workers in improving heart health outcomes. 3, talking about maternal hypertension care to manage high blood pressure during pregnancy and postpartum. And 4, interrelated conditions or comorbidities, like diabetes, chronic kidney disease, and stroke. So if you haven't already, please make sure that you are registered on iEcho so that you can access all the upcoming sessions for this year. We have a lot of great and interesting presentations lined up, and we can't wait to meet monthly to go over all of that. And this brings us to the end of the didactic presentation today. We'd love to open the floor for questions and discussion, even some words of advice from the subject matter experts on the call today. If you have additional input regarding the guidelines, feel free to share. And participants, you can also come off mute or drop your questions, comments in the chat. We welcome everyone's participation. And if this is your first ECHO session, I'd like to just remind you of the model. It's an all teach, all learn model. So we always welcome engaging conversation, and we're here to discuss with everyone. And yes, I see a question in the chat if we can get a copy of this information. Yes, we will send out the slide deck. I think there's an option to also upload the slide deck on iEcho, so you'll always have access to it. And the session is also being recorded, which we will also have access to. Any questions, comments?
I thought you guys did a wonderful job of kind of reviewing everything and putting it into perspective and really hitting some of those points that are helpful for everyone to know. And certainly people understanding that they have hypertension and recognizing that their blood pressure is elevated is huge. And understanding the impact that that makes, the cardiovascular, the risk for heart attacks and strokes. So it's wonderful that we have these great community health worker colleagues who can really be at the elbow of patients and really help in this educational process and help them understand. So thank you guys for this.
Thank you, Emily. And yeah, the guidelines, if Sid or Agner can drop the link to the guidelines, it was on the first slide, that'll be great. So again, we only did a high level overview. That itself was a lot of content, but it gets more in details for anyone interested in reading more about it and to see how it aligns with the work that you do.
I would just like to say I appreciate the presentation. I definitely appreciate the connecting of maternal health to hypertension and talking about preeclampsia. I do want to get off topic and say, well, if some of our rappers can talk about preeclampsia in their record, it helps to educate the population as to what they're talking about. So I appreciated that one. And it's okay that you can't say labetalol and all the other words because they get a little horrendous. But also talking about how race impacts those numbers, those situations, as well as understanding that each body is different. And sometimes there is that little space of individual numbers that kind of can be skewed from the original numbers as to what they mean um, for each individual. But the overall premise was there. And Agna, well done. You did a great job of explaining how high blood pressure impacts and how at the end of the day, the dash really is the key to working on this. And I appreciate the model, all teach, all learn model. So ultimately, thank you so much. I appreciate the presentation.
Thanks, Keith. That was wonderful. Thank you for your kind words. And yeah, Sid and Agner, you did a great job presenting.
Thanks for I was saying it right in my head apparently, T, so I just didn't want to butcher it on the recording, so
That's okay, I understand.
All right, Benita, this is Maxine. So I just want to say shout out to you guys. You guys did an amazing job on your first Echo Series of 2026. I just wanted to also highlight Allison had a question on what to expect as next steps in the series in terms of CHWs. She's interested in hearing more about accurate assessment and the role that CHWs will play in that.
Thanks, Maxine. And Allison, that's a perfect segue as we talk about the upcoming session for February. So next month, we have a presentation by Dr. Carmen Samuel Hodge from the University of North Carolina, Gilling School of Global Public Health and School of Medicine, who will be presenting on her research study on the Carolina Heart Alliance Networking for Greater Equity, also known as the CHANGE program. So the CHANGE program was focused on strengthening clinical community linkages in rural North Carolina counties with CHW delivered evidence-based cardiovascular risk reduction interventions. So that is next month if you want to tune in for that. And the way that we've structured all upcoming sessions and just is getting in touch with presenters who work with or who have experience across the 4 focus areas that we, shared previously: community health workers, social drivers of health, maternal cardiac health, and the comorbidities. So each month we will have, just like those unique presentations that are all aligned with these focus areas in one way or another. And one thing that we do not have today is the case review. So the case review is usually, highlighting a patient case, or if you are from a community-based organization, the case presentations can also look like sharing success stories, program successes, challenges faced, or any other case studies. So we will also look forward to didactic and case presentations in the upcoming sessions. Great question. All right, so again, this is just a look at our team. I didn't mention earlier, but thanks, Maxine, for monitoring the chat today. And, this is the team, the Constellation Regional Collaborative team behind the ECHO series. And it's always a team effort, supporting the planning, outreach, and execution of each session. So we're glad to have you with us today. And special thanks to Sid and Agner for presenting alongside me today as we, kickstart the 2026 series. And participants, feel free to reach out whenever. Our email is listed on the slide. You'll also have this. Oh, I see a typo in the email. If someone can drop in the actual email address in the chat, that'll be great. Yeah, so feel free to share questions. And if you're also interested in presenting a case, definitely reach out. We have, availability. Our ECHO sessions run from January to September every year. So we can definitely schedule you in to share your own work. And last but not the least, the post-ECHO survey. So before we officially close out, we'd appreciate it if you could take a moment to fill out this survey. You can scan the QR code, or if you can, someone can drop the link in the chat. That will be greatly appreciated because the ECHO series is based on continuous evaluation. It helps us, improve or just adapt future sessions according to the interests of our participants. And if you're also seeking continuing education credit, completing the survey is required. So I know we have some extra time, a few extra minutes before it turns 1. So if you wanted to just stay on while you complete the survey, go for it. You can also open the link and complete it whenever you have the availability. But I'd like to say again, thank you everyone for attending today. This was my first session leading as well, so I'm very excited, as you all are, to discuss more about hypertension, cardiovascular health, and get to know all the great programs that exist and are currently, going on in the country.
All right, thank you, Sid, for putting the link and the email address in the chat. And before we close out, again, I'm so proud of you guys. Wonderful presentation. And thank you, Benita, for leading your first Echo series, as well as Agner and Sydney for joining as presenters. So more to come. We're really excited. Benita has done an incredible job planning our series tracks or specialty focus areas that she highlighted earlier. And we're just really excited for you guys to continue this journey with us. Thank you again.
Thanks, Maxine.
Yeah.
And yes, our next session is on February 26th. It will always be on the last Thursday of the month from 12 to 1 p.m. Eastern Time. Register on iEcho and definitely join us every month.
See you all next month.